Good afternoon, everyone, and welcome to our Understanding Health Talk, the second Understanding Health Talk we've held from University Hospitals Dorset. It's a great pleasure to be here this evening to welcome Dr. Chris Critoph and his talk, Understanding Sudden Cardiac Arrest, Why Does It Happen? We're going to be recording this event tonight so that we can share it widely afterwards. We appreciate we may have a few technical issues and we apologise for those, but we hope that you'll be able to see the recording afterwards. Firstly, I'd like to welcome you and to talk about why this is such an important talk. This is a devastating condition that we're going to be talking about tonight, and it's something that can affect us all. So we're very grateful to have the insight from Dr. Critoph on this. Just to talk a bit about the rules of engagement for this evening. We're very keen for you to ask questions in the chat bar, and then we can put them to Dr. Critoph at the end. But this is not a private consultation, so please keep the questions nice and general. And if there's anything that you want to ask that isn't answered, we've also got an email at the end that we'll share, which is communications@uhd.nhs.uk. But we'll put that in the chat bar so you can see that. We're also, we've been sending out details of this to our membership. Members are a very valued part of the University Hospitals Dorset, and we're very grateful to have so many members. But we'll be also including a link on how to become a member and also details of how to become a governor as well, because governors are a vital part of the hospital. But before we start, I'm going to quickly tell you a bit about Dr. Critoph. He's obviously a consultant cardiologist based in Bournemouth, and he trained at major teaching hospitals in both London and Australia before moving to Dorset in 2015 with his wife and 2 young children. He's an expert in diagnosing and treating problems affecting the heart, and is one of the very few UK specialists trained in assessing patients with a family history of heart disease and sports cardiology. He's also responsible for training the cardiologists of the future, so we're really lucky and grateful to have him here today. And as I say, he's going to be giving a presentation for about 35-40 minutes, and then at the end we'll have time for question and answers. So if you've got any questions, please do post them in the chat bar. Thank you very much again for joining us. Apologies for the technical issues if you're watching this as a recording, but now over to Dr. Critoph. Thank you very much.
Thanks very much, Jamie, and thanks for the invitation to speak. And as you said, this is a very tragic but very important topic, and one that's been brought into sharp focus, I think, recently with some of the media events, particularly surrounding Christian Eriksen, the footballer. So I'm just going to outline what I'm going to talk about today. So I'll give a bit of an introduction. I think there's a lot of misconceptions around what a cardiac arrest is, and so I'm going to explain the differences between a cardiac arrest and a heart attack. I'm going to talk a bit about conditions that can cause a cardiac arrest, and there are a few of those, and go into a bit of detail. I'm going to talk a bit about what we do in the world of cardiology in terms of investigating patients that have either at risk or have had a cardiac arrest, then move on to treatment, and lastly finishing up with a bit about the specifics in athletes and some questions and other sort of more interesting bits about how cardiac arrest can happen in a, albeit otherwise, very well group of individuals. So cardiac arrest, well, what is it first of all? So to put it very simply, a cardiac arrest is an electrical problem. So the heart stops very abruptly, and this is usually either a malfunction and a sudden malfunction in its electrical system, or it can be a sudden change in the circulatory system so that blood is no longer being transported around the body. So the picture in the top right will show you typically what happens in a cardiac arrest. So patients will collapse to the floor, and regarding symptoms, usually they will have none, or if they do have any, it will only happen just moments before patients lose consciousness and collapse. Typically patients they'll collapse, they'll be unresponsive, they won't be breathing, and they won't have a pulse. And on the top left here, you'll see this is an ECG, which is an electrical recording of the heart. So this looks at the electrical signals, and I don't know if my mouse shows up on the screen, but if you can see these in the first half of the tracing, Each of these spikes is a normal heartbeat. And then you'll notice that suddenly the look of the tracing completely changes and it becomes chaotic, and the heartbeat suddenly increases considerably. And this is someone who's gone into ventricular fibrillation. Ventricular fibrillation, or VF, is one of the common heart rhythm abnormalities that causes a cardiac arrest, and it is often fatal if not treated very quickly. Now, I'd like to compare that to a heart attack, and as I said in the outset, there's a lot of misconceptions about what a heart attack and a cardiac arrest is. So with a heart attack, let's deal with symptoms first of all. So often symptoms may occur for some hours or even days before someone has a heart attack, and they can vary, but will typically include chest pain, which might be described as a tightness or a heaviness in the center of the chest. It might go to the arm or the jaw. People might feel very fatigued, sometimes feel very sick, and sometimes people can have difficulty breathing. And the symptoms that people get in a heart attack are because of lack of oxygen to the heart, as opposed to a cardiac arrest, where it's a lack of blood supply and oxygen to the brain. So a heart attack is more of a circulation or a plumbing problem. Now, if you look at the top left-hand corner, so you'll see at the top a normal heart artery, and this has got the red circles or red blood cells flowing smoothly through the heart artery. In the middle picture, you'll notice this orange section here, and this is a cholesterol buildup. And you'll see that the blood flow down the heart artery in this picture is compromised, so not enough is getting through. Now, someone who has a blood vessel like this, they might be getting anginal pains, so typically chest pains on exertion. But that isn't a heart attack either. In the bottom picture, you'll see that the surface of this cholesterol plaque has burst open, and these brown blobs are representative of a blood clot, and the whole artery has now not got blood flowing down it, so there's no red blood cells on this side. And this is what happens in a heart attack, and typically people would clutch their chest, like in the top right hand corner, and this is a case of dialing 999, and you'll be seen in hospital and treated accordingly. So what are the risk factors for having a cardiac arrest? And I've put common in brackets because firstly, there are a number of less common causes, but secondly, I wouldn't want people to worry that cardiac arrest is a common finding. It's not, but there's about 30,000 cardiac arrests in the UK per year in the community. So probably the commonest risk factor would be having had a previous heart attack. And so established coronary artery disease or furring up of the heart arteries, if that causes a scar within the heart muscle, then that can be a focus for an electrical heart problem and a cardiac arrest. Or sometimes people can have heart failure as a result of previous heart attacks, and that would also be a risk factor for having a cardiac arrest. If you think about risk factors for coronary artery disease per se, so these would include smoking, high blood pressure, family history of heart problems, high cholesterol, diabetes, and obesity. But heart failure doesn't just occur because of coronary artery disease, and there's a number of other causes. For example, inherited causes, excess alcohol, there's some endocrine causes, valvular heart disease, and a number of others. And then there's more inherited causes, so family histories of sudden cardiac arrest or sudden cardiac death. Now, cardiomyopathy is a word you might have heard, and it's obviously a medical term, but it really implies to a heart that's not pumping very well. And then I'll come on to that in a bit more detail. And inherited heart rhythm conditions, and I'll talk about that as well. So what is a cardiomyopathy? Well, the medical definition, if you look in a medical textbook, is defined as myocardial disorders in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, and congenital heart disease, sufficient to explain the observed myocardial abnormality. Or, in layman's terms, the heart muscle isn't working properly, but we don't obviously know why. But we can do tests to find out why that might be the case. So how do patients present with cardiomyopathy? Well, for the first time, they might present with a number of symptoms. So heart failure symptoms would typically be swollen legs or feeling breathless, and the breathlessness might be worse if you lie flat, for example, overnight. People might present with an arrhythmia, which is a medical word for an abnormal heart rhythm, or palpitations, so feeling the heart going too fast or irregular. And on occasion, people will present for the first time with a cardiac arrest, and it's only after they've been revived and subsequent investigations show what the cause is. People might present with a blackout, and we call that syncope. They might get dizzy for a number of reasons, either blood pressure related or related to a heart rhythm problem. Patients might get chest pain or breathlessness. But quite often, and certainly I see this in clinic all the time, is people are diagnosed incidentally. So the index case, or the proband we call it, it has a diagnosis, and then we offer screening to first degree relatives of that individual and find cases in family members. So I'm going to talk about a few specific inherited heart problems that are causes of cardiac arrest now, and probably the commonest, which I expect many people have heard of, is hypertrophic cardiomyopathy. So a gene for hypertrophic cardiomyopathy is present in about 1 in 500 of the population. But of course, you don't see 1 in 500 of the population dropping dead all the time. And so there's a huge spectrum of disease, from people with very minor forms that they would never know about through their whole life, to people affected at a young age. Typically, people will present in late teens to early 20s, but they can present later on as well. So there's a couple of pathology slides here. So this is a normal heart, a post-mortem specimen cut in cross-section. And this sort of donut-shaped thing on the left is the left ventricle. And this is the right ventricle here. And if you compare, so LVH stands for left ventricular hypertrophy, so a thickened heart. And you can see quite clearly how thick and muscly this area is compared to this one. And so this is a person with left ventricular hypertrophy, and they will have inherited a gene that can cause this from a family member. And there's a few different forms of this, and I'll just outline the basics of them here. So here's a normal heart in a cartoon. Here's someone with hypertrophic cardiomyopathy. And often what happens is there's this bulge in the heart, and this red pipe here is the aorta, and this goes off to supply blood to the arms, legs, head, neck, etc. And this bulge can often get in the way of blood leaving the heart, and therefore can cause a variety of symptoms, including dizziness, chest pain, and breathing problems. So hypertrophic cardiomyopathy is the one of the commonest inherited conditions that we see, certainly in cardiology. The next is dilated cardiomyopathy. So dilated just means bigger than it should be. Cardiomyopathy, again, heart that isn't working as well as it should do. And so if you look at these two specimens here, so here's normal again. This is just displayed back to front from the other one. This is why the right ventricle is on this hand side. And you see how this heart here, this is the dilated one, is very big in terms of diameter compared to this one. But you'll also notice the wall is actually about the same thickness. It's just this black area is where blood would have been in life, and you can see there's a marked difference between the two. And again, this is borne out in the cartoon below this. And so typically a patient with dilated cardiomyopathy might often present with breathlessness, but can have a sudden cardiac arrest. This is a bit less common now. So this is arrhythmogenic right ventricular cardiomyopathy. And so this typically affects the right-hand side of the heart, as opposed to the other two conditions which affected the left. And arrhythmogenic essentially means prone to arrhythmia, causes arrhythmia. And so these patients will often present with abnormal heart rhythms, palpitations, and there has been some very high-profile cases of these, such as England cricketer very recently who had to retire. Channelopathy. So these are rare. These are inherited or usually inherited problems that affect the electrical conduction of the heart. So this is a cartoon of a cell membrane in one of the heart cells, and cell membranes will conduct through them different electrolytes, and in some patients they can have abnormalities of coding proteins which can change the way in which electrolytes can move across the cell membrane and can predispose people to some quite serious heart rhythm abnormalities. But in comparison to the other problems I've talked about, if you do a scan of the heart would actually look normal. And so sometimes these problems are only borne out on the ECG, or indeed in gene screening, which I'll come on to. So how do we test for conditions that might cause a cardiac arrest? Well, this is one of the mainstay of tests. It's called an echocardiogram. I apologise, these were meant to be movies, but unfortunately it hasn't quite worked, but never mind. So these images are gained in much the same way as a lady might have if she was pregnant with using ultrasound. So it's a painless test. It takes about half an hour. Put some jelly on the chest and take some pictures of the heart. Now, what I want you to draw your attention to in this top figure is, if you can see my cursor here, this is the front wall of the left ventricle and this is the back wall. And these markers on the side here are in centimetre gradations. And you'll notice that the back wall is quite thin. Let's say it's about 8 millimeters. And this wall is a lot thicker, probably nearly 2 centimeters. And so this is a patient who's got hypertrophic cardiomyopathy and can clearly be seen on the echocardiogram. If we see hypertrophic cardiomyopathy like this, we can then use a risk algorithm in order to work out what is the risk of that person dropping dead suddenly. So it's actually quite scientific these days. And that algorithm is based on a few different things. So someone's family history, some physiological parameters, whether they've blacked out, and we put all this into a scoring system and then can decide if the patient needs further treatment. In the bottom panel, this is an echo of someone with dilated cardiomyopathy, and the green stuff here is this is a leaky heart valve. But I think before we even get to that, the main part of an assessment is the history taking. So I was taught in medical school that about 85% of the diagnoses are in the history alone. And if we talk to our patients specifically about their family history, then often we can work out a lot of what's going on before coming on to any investigations. This is an ECG, and I've shown you an example of one previously. So it's an electrical tracing of the heart. And we get this by putting some small sticky pads onto the front of the chest and connecting up to a computer system and run this off. It comes out as an A4 printed sheet. And this can give you an awful lot of information about whether a patient might have an underlying heart problem, anything from a previous heart attack to hypertrophic cardiomyopathy to ARVC. So there's a lot of information that can be gained from a very simple test. This is a heart rhythm monitor. So sometimes if we're concerned that patients might have an arrhythmia or a heart rhythm problem, then we can attach little sticky pads to the chest, and that patient will wear this monitor for anywhere from between a day to a week, and we can determine whether or not there is any heart rhythm problem that we need to address. Now, that's all very well if you have symptoms every day or every week, but if you have symptoms only very periodically, and by symptoms I'm really meaning palpitations, then these days there's a lot of technology out there, and smartphone ECG recorders are very good for patients who have intermittent symptoms that can then be analysed by a specialist. And exercise tests. So again, patients might have symptoms at not have symptoms at rest, but they get them when they exert themselves. And so sometimes we'll put people on a treadmill and see how they perform and see whether there's any ECG abnormalities that crop up when they're exercising. So how about some more advanced tests? Well, this is a picture of a cardiac MRI. Echocardiography using ultrasound is fantastic, but sometimes if people are particularly big or have lung disease, for example, then sometimes the images aren't the clearest, and MRI gets around that and gives us some very clear views of the heart, and also some more additional information, so we can give what's called a contrast agent or a dye, and the manner in which that is picked up by the heart can give us some clues as to why a person's heart might not be functioning as well as possible. And in this case, the eagle-eyed will spot that at the apex of the heart here, there is a bulge, and this is actually a blood clot in someone who's had a previous heart attack. So you can imagine there would be some scar under there that might prove a trigger for a sudden death event. This is a picture of a coronary angiogram, and so a conventional coronary angiogram involves having a tube placed usually via the wrist, comes into the heart, and we inject some dye, and we can see whether or not there's any narrowings or blockages that might predispose to any of the problems I've talked about. But actually nowadays, in a lot of cases, we avoid putting tubes into people by doing CT scans of the heart. And you can see here that this is a very accurate 3D representation of the heart, and if you compare the far left to the far right picture, you get an appreciation of the heart arteries running on the outside of this person's heart, and again we can see whether there's any narrowings or blockages. And lastly, this is what's called an implantable loop recorder. So if a patient has had a blackout and we're not really sure why, but there's been nothing otherwise untoward showing up, then these little monitors can be injected under the skin under local anaesthetic. The batteries typically will last up to 3 years, and they will sit there, and if a person has another blackout, we can download from the device and determine whether or not there was indeed a heart problem that needs further treatment. Just a word on genetic analysis. So a lot of these conditions will be genetically inherited, and so the question is, well, firstly, who should we test for a genetic abnormality? And so typically we would start with the most affected person, and you're more likely to get an answer if you pick the person with the most serious disease condition in a family, I mean. Now, let's say, for example, a patient has hypertrophic cardiomyopathy, then that would be that's probably the most likely pickup that we'll find. And even then, you might get between a sort of 50 to 70% pickup rate of finding a gene. How do we do it? Well, it's typically a blood test, but we can also get post-mortem DNA. If someone has died, for example, then we can take post-mortem samples of a heart and analyze them that way. When should we do it? Well, it's a bit dependent on the individual, but and people will argue the toss about whether one should gene screen children. My personal view is that in the vast majority of cases we shouldn't be, but typically for most inherited heart problems we would typically offer gene screening in people's sort of late teens or early 20s. And why should we do it? Well, probably the main reason is to be able to predict whether future offspring have inherited that gene. So if we know that we found a gene that causes a particular condition in a patient, and we know the gene that's caused it, if we're able to then offer that gene test to brothers, sisters and children, then we'll be able to work out what that person's risk is of inheriting the condition and whether they need any further assessment. But for most of these conditions, typically we will screen what's called first degree relatives, so anyone within a generation. So back to cardiac arrest. So what's the initial treatment? Well, this falls into two camps really. There's basic life support and advanced life support. So if there's one takeaway message from today's talk, I'd really like you to learn basic life support, because there are lots of courses available, and I'd urge you to have a look at the British Heart Foundation website. And those courses, there's online courses as well, and face-to-face I'm sure will be opening up as the pandemic does. But basic life support can really make a difference. And I've lost count of the number of patients that I've seen personally in hospital whose lives have been saved by the quick actions of a loved one. It's relatively straightforward to do. It doesn't take much training, and it really can make a difference. Advanced life support is obviously a bit more complicated, and usually the preserve of ambulances or in hospital, but basically it involves defibrillation. So defibrillation is the key for the majority of causes of a cardiac arrest as an outpatient, because it will treat these abnormal fast heart rhythms. We're very used, I think, now to seeing automatic defibrillators around the place in supermarkets and gyms and so on. They're very straightforward. You don't need to do anything other than plug it in and put the pads on, and it will show you where to put the pads on a patient, and they will guide you through with voice prompts, and there's only usually one button, so it's nothing to be feared, and as I say, it can save people's lives. I think there is a sort of a move to try and make these legal in some places, legal requirements. So, for example, in gymnasiums, and I think that's a really good idea. It's the technology is available, so we really should see these being more widespread. So, how about further treatments? Well, simple treatments after a cardiac arrest are education. So, it's education about lifestyle advice if patients have had a heart attack, for example, do's and don'ts, exercise advice, and often cardiac rehabilitation is hugely important. Exercise, and for those of you who know me, I'm very keen on sports and exercise, but it's hugely important in terms of reducing your overall risk of a heart attack, and therefore of cardiac arrest, and I'll show you some data about that. And then, of course, there's medication, and if people have had a cardiac arrest, invariably they will end up on some medication to try and help prevent this happening again. Now, how about longer term treatments? Well, if someone's had a cardiac arrest, typically the treatment is an ICD, or an implantable cardioverter defibrillator. I expect most people have heard of a pacemaker, which is a small metal box that's typically implanted under the skin, just under the collarbone, and has a wire that goes into the heart. And that with a defibrillator, the difference is that a defibrillator can do everything that a pacemaker can do, but it will monitor the heart the whole time. And if it sees a heart rhythm that could be potentially life-threatening, it can either give some very fast impulses to the heart, or worst case, it will give an electric shock to the heart to bring the patient round. Now, typically, if this happens, a patient won't be awake; they'll be on the floor. So it's a life-saving thing that happens when they're unconscious. And we do a lot of work with educating patients and patient support groups in this regard. If a patient has a blocked artery as a cause of their cardiac arrest, then that will need to be reopened. And this is a picture of a stent sitting inside a coronary artery. And this is something that certainly for heart attacks is an emergency life-saving treatment. And in some cases, and this is rarer in cases of sudden cardiac arrest, but there are catheter ablation treatments which can be used to try and reduce the risk for the future. So I'm going to talk a bit about athletes now. So on the left here we have Fabrice Mwamba. And Christian, so Fabrice Mwamba, you may remember, I remember it very well because it was my then boss was the Dr. Andrew Diener, was the cardiologist who happened to be a Spurs fan and rushed onto the pitch to lead the cardiac arrest. And at the time, this was a big wake-up call, because there hadn't been a really high, certainly not in football, a high-profile event. And very recently, Christian Eriksen had a cardiac arrest, as you know, and he has now been fitted with a defibrillator. And on the right here's a chap called Justin Edinburgh, who used to play for Spurs and was latterly the Leyton Orient manager. And he suffered a cardiac arrest in a gym and was unfortunately died in his, I think he was in his late 40s. And so his son is now leading a media campaign to try and make sure that gyms are equipped with defibrillators. But surely athletes are fit people. They're they're trained. They are subject to routine medicals, including cardiovascular examination. So how does this happen? Well, unfortunately, despite best efforts, there is a risk that things get not necessarily missed, but can be misinterpreted, or in a certain number of patients, particularly some athletes, they can have a lot of structural changes within the heart that might be normal for them, and in some cases adaptive responses to exercise, but that can predispose to sudden death. And if you look at the literature, the incidence is about 1 in 50,000, and in young athletes, the average age of death is about 23, with 40% dying less than the age of 18. Typically, it's more common in men and more common in black athletes than white athletes. And the vast majority of cases occur immediately after, or either during or immediately after exertion. And if you look at in the UK registry, the cause of sudden death in sports, that nearly half are caused by sudden arrhythmic death syndrome. So these are in people whose hearts are structurally normal, and yet they still have a cardiac arrest, and that further explains why athletes might have a cardiac arrest, and yet nothing would have shown up in screening beforehand. And you can see on the pie chart here, there's a smattering of the other bits and pieces that I've talked about earlier. So what are the triggers? Well, typically there's a few things that can predispose to this, so sort of set the scene. So dehydration for one, then obviously your adrenaline will be surging during exercise, electrolytes, so salt imbalances, and I personally would always rehydrate with sports solutions now after exercise. And this can lead to disturbances in what's called your acid-base balance, which is really a measure of how acid or alkaline your bloodstream is. And those abnormalities can predispose you to an abnormal heart rhythm, which can trigger sudden death. So if you look at it, actually, interestingly, the relative risk of dying suddenly if you're an athlete is about twice that of a non-athlete. So you're twice as likely to die. And you might think, well, gosh, why do people do athletics then? Well, I'll come on and show you some good data as to why. But this is actually, in some ways, preventable. So Italy is well known for being very sort of advanced in screening of athletes. And this is a graph, so the red line is athletes and the yellow line is non-athletes. And in the 80s, they started to begin screening of athletes. And by screening, I'm typically talking about an ECG. And then if an abnormality was picked up, they went on to have further screening. And you can see actually that their pickup rate will have gone up, and therefore the trend and the incidence of sudden death decreased significantly over time, such that now you're actually safer in Italy if you're an athlete compared to a non-athlete. So how about older people? So, and by older, I'm afraid this is more than the age of 35. So if you look over the age of 35, actually coronary disease becomes so CAD is coronary artery disease, becomes far and away the leading cause of sudden death in so-called senior athletes, and sadly I'm also in that group. But there are again a smattering of other problems, so valvular heart disease, hypertrophic cardiomyopathy, and so on. But I'd like to impress the point that when you start exercising, you might think, oh, I'm not really getting very far here, I don't feel any fitter. But if you look at on the x-axis, you've got the volume and intensity of activity, and then the level of benefit on the y-axis. And you'll see that when you start exercising, you don't actually really get any good fitness benefit until you're up at the moderate frequency and moderate to high intensity threshold. Whereas actually, if you look at the health benefits, you can get that by doing very low intensity exercise and only moderate frequency. And you'll see that curve is very steep at the beginning. So by doing very little, you can actually get some health benefits without fitness benefits. And so I'd really encourage people to take that on board and think, even if I don't feel any better, I'm doing myself some good. This graph I'll explain for you. So this is looking at, so hazard ratio is how likely something is. So METs, this is how active you are, And the more active you are, and this is the likelihood of getting heart failure. And so the more activity you do, the less likely you are to get heart failure. And this is the same data displayed slightly differently. So light physical activity, moderate physical activity, and high physical activity. And so you'll see that the chances of getting heart failure reduced about, what's this, probably about 15 to 20% by doing light activity, 20% by moderate, and about 30% reduction by doing high physical activity levels. So you can really make a difference. And this is a real problem because in the UK, we are an obese nation and we are an inactive nation. Now, in the Southwest, we are certainly better than some places, but in the UK, but nevertheless, we need to be doing more to get people active in the UK. So what services are available locally? Well, we're very fortunate in Bournemouth that we've got a very, very well-developed cardiac unit with tertiary level services. So we're one of the busiest centres for cardiac interventions. That's putting stents in, electrophysiology and ablation. Across Poole and Bournemouth, our imaging is one of the busiest in Europe for cardiac CT and cardiac MRI, and we have a very active heart failure service. We have a number of patient support groups, and in particular with regard to cardiac arrest, the Bournemouth area defibrillator or BAD support group has been set up by one of our nurses a few years ago and supports patients who have got defibrillators and their families. I run the inherited cardiac conditions service, so this includes genetic screening for people who have got inherited heart problems, and this is one of the only clinics certainly in the south of England outside of London. We also have a very active cardiac rehabilitation program for people who have suffered a heart problem of one sort or another. So to summarise, I hope that I've explained the difference between a heart attack and a cardiac arrest for you. I've summarised the routine cardiac investigations that people with both of these conditions will go through, and also what treatments are available. And if there's two takeaways from this, the first would be to learn basic life support, and the British Heart Foundation has got a lot of information in that regard. And the second would be to encourage you to be physically active, because you will reduce the risk of your heart having problems in the future. And Jamie, I'll leave that there and take any questions that we might have.
Thank you very much for that talk, Dr. Critoph. Very interesting and fascinating, and really good advice at the end, especially about the learn basic life support. I think we can all learn from that. We do have some questions that have been sent in, which I hope I can give to you. Starting with this first one: is sudden cardiac arrest hereditary?
So there are some conditions that are hereditary that can predispose to sudden cardiac arrest. So, for example, the channelopathies, the electrolyte across the cell membrane ones, so they can be inherited. Hypertrophic cardiomyopathy would be the commonest one, so that's certainly an inherited condition. That said, cardiac arrest is still uncommon in that condition, but yes, in that regard it is. However, there will be other conditions. So the commonest cause of cardiac arrest would be an old heart attack. And whilst that is hereditary to a degree, i.e. it is more likely if one of your family members has got it, there's a lot more what we call modifiable factors that will impact on that. So smoking history, diabetes, blood pressure, and so on. So I hope that answers the question.
So thank you for that. Next question, we've got a few questions about ICDs, so I will run through them one by one if you don't mind.
Sure.
The first one is, can you get a shock from an ICD if you're with a person who has one fitted?
No is the short answer. Yeah, I mean, it can be typically that the body will jolt, but it shouldn't be. It's delivered very locally to the heart. You should still stand clear, but yeah, you shouldn't get a shock yourself.
Fantastic, thank you. Another question: I've heard that induction hobs impact ICDs. Is there any truth in that, or anything else that might interfere with them?
Sure. So the issue here is with what's called electromagnetic interference, or EMI, and this is the same goes for pacemaker, but pacemakers. Essentially, EMI has a very fast frequency of signal, and what one needs to be careful with is that the pacemaker or ICD sees this electromagnetic interference and thinks, that's ventricular fibrillation. In the case of an ICD, would shock it, would shock the patient. So we do advise patients to not use induction hobs if they have a cardiac device. Similarly, things like arc welding, or professions that use that sort of anything that could be misinterpreted by the device as an abnormal heart rhythm. So yeah, I would avoid induction hobs with these devices. I mean, you have to still be pretty close to them, but one should be careful.
Thank you for that. And we've actually had a question come in on the chat bar. How can you lower your blood pressure when on tablets?
So, okay, well, I'm guessing that if you're already on tablets, then tablets should lower your blood pressure. I would start by going back to the point at the end of my talk, that physical exercise is a very good way of lowering blood pressure, both with weight reduction and the exercise itself. And so lifestyle modification would always be the first port of call for treating blood pressure, whether it's diet, exercise, and so on. Beyond that, there are a whole variety of different medications that can lower blood pressure, and it's usually a case of it depends a bit about age and ethnicity, but typically you would pick one from a group, and if that fails to control the situation, either adjust the dose or add in another, and so on and so forth until the blood pressure is controlled.
Brilliant, thank you for that. And we've got a question here from Diana. If cardiac arrest is hereditary and the person does not display any symptoms, should that individual still seek medical advice?
I'm assuming it means the relative of that person. So it all hinges on what the cause of cardiac arrest was in the person that had the cardiac arrest. So, for example, if the person who had the arrest had let's say a bog standard heart attack, let's call it, and then had a cardiac arrest on the back of that, then that is not something that we would routinely recommend screening of relatives. However, if the person that had the cardiac arrest had a potentially inherited heart problem, such as hypertrophic cardiomyopathy, then absolutely that person should then be referred for screening with an ECG and an echocardiogram by a cardiologist who will be able to advise on that.
And we've got another question here on ICDs. What happens when someone with an ICD fitted actually dies? Does the ICD keep on working, or what does it do?
Yeah, interesting question. So there's a couple of different facets to this. So firstly, when people are getting towards the end of their life, and this might be predictable, let's say someone's got end-stage heart failure, or I don't know, a cancer or something that is going to be terminal for them, then provided we know about that with a bit of notice, let's say a day or two, then we would really look to deactivate the ICD. That doesn't mean having an operation or anything. It's done remotely, so we can do it essentially via a computer next to the patient, and we can turn off the bit of the device that would give a shock in the event of a rhythm that could kill someone. So hopefully we would get to the point that actually it's very unlikely that a patient's ICD would go off if they were getting to the end of their life. Now, the second answer to that is that let's say, and I have to say I don't think I've ever seen this, but if a patient had an ICD implanted and they died of something else, and it was still in, then the ICD would still be monitoring to see what was going on, but it just wouldn't be seeing any signal, and therefore it wouldn't actually do anything. And the third scenario I can think of would be if they are only programmed to give a certain number of shocks, and if despite X number of shocks it hasn't managed to bring the patient round, it wouldn't then continue to shock and shock and shock.
Brilliant. Thank you for that. Thank you, Chris. Another question on ICD. What's the difference between an ICD and a pacemaker? Is one more effective than the other?
So the difference is that the indication, the reason why you would put one in. So an ICD can do everything that a pacemaker can do, but has additional functionality. So a pacemaker typically is put in to treat slow heart rhythms, and it won't do anything about fast heart rhythms. It will just speed up the heart if the heart's going too slowly. Whereas an ICD can do that, but it can also give the heart either an electric shock or some fast heartbeats, which I won't go into, but there are ways and means of it dealing with fast heart rates before it gets to the stage of needing an electric shock. So yeah, you would have a pacemaker if you were at risk of slow heart rhythms or had slow heart rhythms, but an ICD if you were at risk of having sudden cardiac death.
Brilliant. And we've got another question on the chat bar. As I say, this isn't a private consultation, but it's a question that I'm sure you can answer in general terms, Chris. If I already have intermittent arrhythmia, but doctor has said it is okay, however, now arrhythmia now showing every time I use home Omran Evolve BP machine, I think it says, should I seek further advice?
So from the sounds of it, so an Omron is a manufacturer of blood pressure machine, and typically a lot of blood pressure machines these days will also be able to pick up if your heart rate is regular or irregular. Now, the commonest cause of an irregular heart would be atrial fibrillation. Now, that's not a risk factor for having, or not in the vast majority of cases for having a cardiac arrest, but would need other treatment, typically, for example, blood thinners. So the question is, it depends exactly what the heart rhythm is that the monitor is picking up. And so typically you would need, or a patient would need a more, let's say, in-depth assessment, typically wearing a heart monitor, such as the one I showed earlier in the investigations, to determine what the heart rhythm problem was and then treat appropriately. But it has to be put in the context of patient symptoms.
Brilliant, thank you for that. And I think sort of coming back to that a little bit, another question's come in. Can an irregular heartbeat lead to a cardiac arrest?
So, as I say, the commonest cause of an irregular heartbeat is atrial fibrillation, and that in and of itself, certainly for the purposes of this talk, can't lead to a cardiac arrest. Stroke would be the biggest risk of atrial fibrillation. There are other causes of irregular, ventricular fibrillation is would have an irregular rhythm if you looked at it on a monitor, but actually would be not associated with a pulse, and therefore is by definition a cardiac arrest. But I think that the short answer to the question is no, for the purposes of what we're talking about here.
And a question picking up of your advice on exercise. Would you recommend, because I know you're a keen sportsman, as you said, there's obviously bicycling, running, swimming, walking, all sorts of things. Is there any particular type of exercise one should be aiming for? And I know lots of people wear sort of heart monitors. Is there any sort of perfect zone they should be aiming for when they're doing exercise?
Okay, so there's quite a lot in there. I think the what I always say to patients is, you've got to pick something you enjoy. There is no point saying, I'm going to go and get fit running or have you if you hate running, because you just won't do it. And this has to be something that you enjoy, that you can incorporate and make a good habit of for the long term, or else it just won't stick. And it might stick for a few days or a few weeks or a few months even, but the point of this is it's ingraining positive lifestyle choices for the rest of your life. And so honestly, it doesn't really matter. Now, that said, there are, so we call it static and dynamic components of exercises. So for example, something like weightlifting might have a high sort of static or isometric component, and something like, I don't know, running will have a very high dynamic component. And the differences between the two do have different effects on your physiology and different effects on your fitness. Now, there are tables that you can find online that will sort of put different sports and different activities into different boxes depending on how much different components of athletic attributes there are. Now, in terms of training zones, I mean, there are people will sort of argue about this, but by and large, that it will depend a bit on how old you are. It will depend a bit on how fit you are, because there's something called VO2, which is your oxygen consumption, and that can be measured with a specific test. And if you know what your heart rate is at the point at which your body becomes anaerobic, so that's typically when you start to get a stitch and you can feel lactic acid building up, then you can design training programs around your heart rate when you become anaerobic. And therefore, so for example, HIIT exercise people will have heard of, I'm sure. So high intensity interval training is probably the best mode of training to get fitter, and that's when you're dipping in and out of these fast heart rate zones and dipping in and out of your, we call it your anaerobic threshold, to try and improve your athletic performance. But I think that's really more at the higher end of training, whereas at the bottom end, really, anything is better than nothing. Just keeping active. Actually, I would just add one thing on that. Having said that, with keeping active, and yes, it's better than nothing, but really you need to be getting breathless, and it's about getting comfortable with getting uncomfortable. And I do have a lot of patients say, well, I'm very active and I have a busy job and so on, and that's great, but the studies would show us that that's not actually enough to necessarily reduce your risk. And it is that proper physical exertion where your heart rate's going and you're getting breathless that has the most benefit.
Fantastic. Well, we've sort of come to the end of the hour. Again, I'd like to apologise for the technical issues, and thank you for all those who sort of persevered and managed to join on our new link. And as I say, we will be sharing the recording of this event more widely with our membership and also through our social media channels, etc., etc. So people who weren't able to join this evening will have an opportunity to do that, because I think it was a fascinating evening. I just want to take this opportunity to say thank you so much for Dr. Chris Critoph for his time this evening, for sharing his expertise, and for such a fascinating talk. As I say, I'm sure this will touch all of our lives at some stage. So it's really good to be prepared. And I think learn basic life support is my one take home from this. So thank you so much. Thank you all for joining. And thank you, Dr. Critoph.
Pleasure. Thank you.